Imagine this. You can hear someone's voice perfectly. You can tell if they're happy or sad from their tone. You can hear the rhythm of their words. But the words themselves, they're just noise. You can't decode them. That's a real quote from a patient, and it just perfectly captures the strange, isolating world of aphasia.
So, welcome to our clinical masterclass on aphasia. And look, this isn't just some fascinating neurological puzzle, though it is that. Understanding this is an absolutely critical skill for any clinician who walks into a room and finds a patient who's suddenly lost their ability to communicate.
All right, here's our game plan. We're going to start with a clinical mystery, then we'll master the bedside exam. After that, we'll use that framework to map out all the different types of aphasia. We'll even dig into some atypical cases before we get to diagnosis and treatment, and we'll finish up with a little self-test to make sure it all sticks. Let's dive in.
Okay, let's start where you'll often start, in the clinic or the emergency room, with a scenario that happens every single day, a patient who, out of the blue, can no longer speak. So let's meet our patient. He's 68, he's right-handed, and we'll see why that matters later. About an hour ago, his family says he was totally normal, and then, boom, he started struggling to find his words. Now, that sudden acute onset, that should be screaming one thing at the top of your mind: stroke. That's our number one suspect. But what exactly is going on with his language? To figure that out, we can't just guess. We need a system. And that brings us to our next section, the bedside language exam. This is your essential toolkit for decoding any language problem you encounter.
And really, this whole exam is built on 4 pillars. First, you just listen. Is their spontaneous speech flowing, or is it choppy and effortful? That's fluency. Second, you test their comprehension. You give them commands, from simple to complex. Third, you check repetition. Can they repeat a simple phrase back to you? And fourth, you assess naming. You point to a pen and ask, "What's this?"
Now, when you're assessing fluency, you might hear something called telegraphic speech. This is a huge clue. It's the classic sign of a non-fluent aphasia. Think of an old-school telegram, where you paid by the word so you'd leave out all the little filler words. That's exactly what this sounds like. The speech gets stripped down to just the main nouns and verbs. All the little connecting words are gone. It's halting, effortful, but packed with meaning.
Okay, so once you've done your exam, you're not just holding a random list of symptoms. You have the clues you need to actually name the syndrome. And that's what we're going to do now. We're going to map the aphasias.
Let's start with the 2 big ones, the 2 you've probably heard of. First, there's Broca's aphasia, also called expressive aphasia. The easiest way to remember this is Broca's is broken speech. The patient knows exactly what they want to say, the thought is there, but they just can't get the words out. Now, Wernicke's, or receptive aphasia, is the complete opposite. The speech is fluent, but it's often a nonsensical jumble of words, what we call a word salad, and the tragic part is they can't understand you either.
And this table right here, this is your diagnostic map. It looks like a lot, but it's beautifully logical. By using just those 3 key findings, fluency, comprehension, and repetition, you can systematically figure out which syndrome you're dealing with. See how Broca's is non-fluent, but comprehension is good? And Wernicke's is fluent, but comprehension is poor? But look, they both have poor repetition. That repetition column, that is the secret key that unlocks all the other more subtle diagnoses. Okay, let's take a look at a really interesting one. Conduction aphasia. This is a classic disconnection problem. Think of it this way. Wernicke's area, where you understand words, is working fine. Broca's area, where you produce speech, is also totally fine. The problem is the highway connecting them, the arcuate fasciculus, is damaged. So what happens? The patient can understand you just fine, and they can speak fluently, but they have this profound, isolated inability to repeat back what you just said. The signal just can't make the journey. So why does aphasia almost always point to a problem on the left side of the brain? It comes down to this incredible statistic. In 99% of people who are right-handed, language lives in the left hemisphere. This makes aphasia one of the most powerful signs in all of neurology for telling you which side of the brain has the lesion. But, clinical reality is rarely as neat as the textbook. So let's move on and explore some of the atypical cases and the different causes of aphasia that aren't your classic stroke.
And the single most important clue to the cause is the timing. It's all about the onset. If it happens acutely over minutes to hours, you're thinking of a vascular event like a stroke or maybe a seizure. But if it's gradual, creaking up over weeks, months, or even years, now you have to think about something that's slowly growing, like a tumor or a neurodegenerative disease.
So, here's a quick case. A 65-year-old comes to you complaining of a year of slowly getting worse at finding words. You get an MRI of their brain, and it's normal. No stroke, no tumor. What are you thinking? Well, this picture is a classic for something called primary progressive aphasia, or PPA. This is a type of neurodegenerative disorder, kind of like Alzheimer's, but instead of starting with memory loss, it starts specifically in the language centers of the brain.
Now check out this case. This one is just mind-bending and really shows you how complex language is in the brain. The source material talks about a bilingual patient who had a single stroke, and afterwards they had a motor Broca's type aphasia for their native Spanish, but a sensory Wernicke's type aphasia for Hebrew, their second language. I mean, wow, that tells us that different languages might actually be wired into different distinct circuits in the brain.
All right, so we've worked through the case, we've nailed down the diagnosis. Now what? Let's talk about the clinical path forward. How do we make sure it's not something else, and what can we actually do to help our patient?
First things first, you have to rule out the mimics. Is it dysarthria? That's just a motor problem with slurred speech. The grammar and word choice are totally fine. Or could it be the disorganized thought from schizophrenia? Or maybe the global confusion you see in delirium? You see, the whole clinical picture is absolutely essential to tease these things apart.
When it comes to treatment, intensive speech therapy is the absolute cornerstone, especially for a fixed injury like a stroke. Now, pharmacologically, a lot of drugs have been tried, but the best evidence we have from good placebo-controlled trials points to a drug called paracetam. At a dose of 2,400 milligrams twice a day, it's shown the most consistent, though modest, benefit.
Okay, let's bring it all home. We're going to wrap up this masterclass with our final section, a quick review and a little self-test to make sure these concepts are really locked in.
All right, let's test your reasoning. You have a patient. Their speech is non-fluent and effortful. Their comprehension is totally intact. But, and here is the key, their repetition is perfect. What is the diagnosis? That's transcortical motor aphasia. It looks a lot like Broca's, right? But that perfect repetition is the giveaway that tells you it's a different circuit that's been affected.
Okay, one more. A patient's speech is nice and fluent, but it's full of word errors. They understand you perfectly, but when you ask them to repeat a simple sentence, they just can't do it. What's the syndrome? That is the absolute classic picture of conduction aphasia, our disconnection syndrome.
So for your final rapid-fire revision, if you remember nothing else, remember this. The exam is built on the big three: fluency, comprehension, repetition. Your memory hooks: Broca's is broken speech. Wernicke's is word salad. And the clinical story is everything. Acute onset means vascular. Gradual onset means degenerative or a tumor.
You know, aphasia gives us this incredible window into the brain, showing us that language is wired into specific networks. But it leaves us with a much, much deeper question. When a patient can't speak, but they know exactly what they want to say, what does that tell us about the nature of thought itself and its relationship to the words we use? That's something to think about.